Thank you for inviting me to the FESSH committee to talk about thin cutaneous flaps, tips and tricks. My name is Nikkhah, and I'm a plastic and reconstructive surgeon based in London. So my workhorse thin flaps in my practice are the ALT flap, the skip flap, for digital defects, often the venous flap, thenar flap, and the toe pulp. It's really important to select your cases appropriately when using thin flaps. Firstly, you've got to ask, is the patient suitable for a complex flaps reconstruction? Sometimes the simplest option is free flap reconstruction. You've got to consider which recipient vessels you use, whether you can go for a perforator to perforator anastomosis, and you've also got to consider an aesthetic donor site. So this is a complex defect of the elbow. You can see that I've done a CT angio, and you can see some perforators coming off, which would be perfect for a thin flap, like a skip flap, to do an end-to-end anastomosis. Means that you don't have to do deep anastomosis end to side. The donor site is also really important. You see at the top here is a patient of mine who's got a sarcoma, will need radiotherapy. They can have a suprafascial thin ALT flap, but the donor site will be a disaster. So in their case, I've taken tissue from the abdomen and done a DIEP flap to resurface this area. This is a like-for-like reconstruction, and you can get a beautiful result. Fist and open it out and a fist. This is a patient amazing that you at 7 months post-op. The anterolateral thigh flap is really the workhorse flap for most trauma units. I often do this as a single perforator flap. In some cases, a subfascial flap is necessary. In this case, a patient has had a suprafascial flap to cover the back of the hand and getting a pretty good result. In for me and then bring them out. Still pretty bulky. Actually, and in the Western population, these flaps are a bit thicker. I often approach using a medial approach. This is a subfascial flap. When you're starting out, you can start these as subfascial, but as you become more experienced, you can go suprafascial. You can take the fascia around the area where I'm pointing to on the perforator. Often it's good to do a wide incision so you can see the cleft between the vastus and the rectus. Simple things like basing your perforators more distal, you're going to get a thinner flap. And these pictures are in my book. You can see the demonstration of how much thinner it gets more distally. Those of you who've raised this flap, it's really important to use bipolar. You can use the de-roofing technique, which is popularized in Taiwan, to go through the muscle when it's an intramuscular course. This is a patient of mine who's had a suprafascial ALT flap for Merkel cell tumor of the elbow. You can see a fantastic result. The skip flap, I learned this flap from one of my teachers at East Grinstead. This I usually use for defects on the hand, on the lower limb. It's great for delayed reconstructions, low energy, and be prepared to do end-to-side anastomosis and be prepared to use super microsurgical instruments. It's got a very concealed donor site, unlike something like a radial forearm flap. It's pretty thin tissues. On the Western population, I think it's a little bit more difficult, particularly patients of ours who have higher BMI. You can see here I've done a medial approach. This is popularized by Koshima. Vessels are very superficial. You can raise this flap within uh, 15 to 30 minutes if you really need to. You can see the anatomy that I've demonstrated in a paper. So this is that same patient who'd had the CT angiogram originally, skip flap to the elbow for robust coverage. Here's another patient who's had a ring avulsion injury and has had their digit buried by another surgeon. Um, I think if I were to see this patient primarily, I would probably amputate the digit. Patient wanted to salvage the digit, and we did a free skip flap, an acceptable result. But I think the only problem is the rehabilitation and rehab that you need to achieve even this moderately good result is pretty intensive. Microsurgical reconstruction of the digits. I do use the toe. Recently, I've used the thenar flap, which is a good option, and also the free venous flap. So we all know the goals of fingertip reconstruction. You can see this is a patient of mine who I've done a Venkatswamy flap. You want to maintain joint function, aesthetics, sensation, and coverage. This is a patient who's had a volar oblique amputation of the thumb. And in their case, they've had a free thenar flap. This is a very nice flap to raise. You can raise it under regional anesthetic, as it was demonstrated in this case, and you can get a pretty good like-for-like reconstruction and minimal donor site problems. Toe-to-hand transfer. Um, I rarely do toe-to-hand transfer in my practice, but be wary when you're using the great toe, particularly the donor site issues. Second toe, I have seen used in children um, in terms of great toe pulp. This is an option that you can do this case in patients who've had pulp defects. You can see that like for like reconstruction with the glabrous tissues, it can't be matched with any other free flap. This is a patient who's a fine carpenter who's lost bone and tendon and joint from the index finger, and he didn't want an amputation, so he's had an osteocutaneous toe transfer. And this is just a demonstration of
The
us raising the flap with a retrograde
approach to the plantar.
You can use ultrasound to determine the force
This is
of the vessels.
direct.
Here you can see the same patient
Take a fist.
with just one operation.
Okay, and on the other side as well. Open it out.
Pretty good in terms of the donor
Up
site.
in the air. Okay, like
The venous flap is a flap that I have used when other donor sites are not available. This is a patient who's had a shunt restricted venous flap, professional footballer, to save his digit. He's done pretty well. I think some tips for venous flaps. One of them is you can do some manual compression to identify all the veins. It's important to use multiple outflow veins, shunt restrict before transfer, and make sure that no more than a quarter of the flap is supplied by arterial vessel. So this is a picture from a book, a case done by one of my colleagues, a venous flap for resurfacing a thumb defect. You can see that it can be taken with vascularized palmaris longus and it can provide a beautiful and elegant reconstruction. So it's really important to tailor the flap to the individual. Sometimes the best option is a free flap and think like for like reconstruction. Think about your donor site and think about the suitable recipient vessels that you can use. Um, you can do more reading in my books and also on the educational content that I have online. Thank you very much.